Hey everybody, welcome back. So today, my goal with this video is to talk about the normal sinus rhythm and to talk about my approach to the ECG and apply that to a case of normal sinus rhythm. And so this will help you guys understand how to master what you would expect to see on a normal ECG and normal cardiac electrophysiologic behavior, so that whenever you apply these steps and a fundamental understanding of the normal sinus rhythm to ECGs that are deviations from that you have pathology on, then you will ideally be able to identify the physiology associated with that ECG strip, right? And so that will help tailor and help you understand your treatments and response to treatments and everything. And so I'll quickly just recount the normal cardiac conduction system, right? I'll use this heart diagram in the top left corner. And remember that the steps of depolarization start off of the heart. You start off here with the SA node. So my SA node is high in the right atrium, and it fires off. And when it fires off, it produces a wave of depolarization across the atria. And that wave of depolarization is our P wave, right? And so our P wave is our first step of depolarization. The next step of cardiac conduction occurs when that wave of depolarization reaches my AV node. And we know that the AV node delays that signal. And why does the AV node delay the signal? Well, whenever the atria depolarize, they squeeze and they push blood from the atria down into the ventricles. And by sending blood into the ventricles need a split second to fill. And so the AV node delays that signal by 120 to 200 milliseconds, which is 3 to 5 little boxes on the ECG. The AV node delays that signal so that the ventricles can fully fill with the atrial contraction. And so when the AV node finishes that delay of signal for 120 to 200 milliseconds, it then passes the signal down into the ventricles. And when it passes the signal down, it starts our QRS complex, and the QRS is what represents depolarization of the ventricles, right? And so then we can infer that the time between the P wave and the QRS is represented by the PR interval, and the PR interval is essentially representing my AV node, right? Because that's the time between the start of the P wave and the start of the QRS, which is represented my AV node pausing. And so then the AV node sends our signal down, and our signal travels through the bundle of His, down through these His-Purkinje fibers, our left and right bundle branches, our fascicles, and these are rapidly conducting fibers. And that allows for the depolarization wave throughout the ventricles to occur fast. And so we know that time is on the x-axis of our ECG. And so our narrow QRS, which is a QRS that is less than 120 milliseconds or 3 small boxes, that tells us that the conduction throughout the ventricles is via these fast conducting fibers of the His-Purkinje system. And so we know also that all, wave of depolarization will also follow a wave of repolarization. And so after our QRS, we will have these T waves that represent repolarizing ventricles. Repolarizing of the ventricles. And so you might ask, well, don't the atria need to repolarize? They do, but remember the atria is a very thin muscle layer compared to the ventricles, right? The ventricles are pumping it out to the rest of the body. And so the atria, the P waves that are created by the atria are very small in amplitude when compared to the QRS waves that are generated by ventricular depolarization. And so you can't really see the repolarization of the atria because it's just a small amplitude, right? And it's typically buried within some of the next complexes. And so based on this order, kind of the order of operations, we see typically each complex, each ventricular, or contraction of the heart, we will have at first the P wave, because the atria contract first. Then we have a little bit of pause, Then we have our QRS complex representing ventricular depolarization. Then we will see after it our T wave for our ventricular repolarization. And so that tells us that there is some type of organization of our cardiac electrical activity. And so let's apply these concepts to this ECG. Let's go through my approach to the ECG and how we can apply the physiology of normal sinus rhythm here. And so let's get started. And so you always notice that my first step of ECGs is to look at the forest. And what I mean by that is imagine that all of these QRS complexes were little trees, right? That's my poor drawing of a Christmas tree type tree. These are all little trees, right? And so we want to understand what is the organization of our forest that is made up of QRS complexes. And so the first thing I do is I look and I see that we have a narrow complex rhythm, right? So the first question I might ask when I look at the forest is, are my QRSs narrow or are they wide, right? And this tells me if my conduction throughout the ventricles is via the His-Purkinje system that we talked about before. If it is, that tells me that we've got a signal that is likely coming from at or above the AV node. And so I look and just with my eyes and I see that these seem to be less than 3 small boxes in width, right? Because time is here on my x-axis is time. And so I look at that. If it's a sinus rhythm, I know my sinus node is a very predictable node, right? And my sinus node is what is driving the rhythm. So I should see a pretty regular rhythm. There could be some small deviations in the rhythm, but notice that it's very regular all throughout this ECG. And so when I see a regular, narrow, complex rhythm, I start to wonder, okay, this is starting to be more like a sinus rhythm, right? So I also look at the regularity. And then I look at the rate, because I know that the sinus node typically is at a normal sinus rhythm will conduct at a rate of 60 to 100 beats per minute if there's nothing going wrong. And so I check my rate out and I like to find maybe a QRS that lands on a solid line, and I'll count 300, 150, 100 would be that solid line, 75 would be this. So I know it's somewhere between 100 and 75, more closely to 100. So maybe I would say that this rate is at 90 or so beats per minute. What I know at the end of the day is that we're between that 60 and 100 beats per minute. And so now I have my rate as well. And so all of these things put together, you're starting to really think that since we have a narrow complex rhythm that is pretty regular at a rate between 60 and 100, starting to behave like the sinus node would behave. And then you can glance really quickly and you can see we have these lower amplitude P waves that are kind of sharp deflections. P waves are typically sharp in front of my QRS complexes. And so I'm starting to think this is likely a sinus rhythm. And so then the next thing I do is I need to evaluate what do those P waves look like. So I'm going to go from start to finish of our electrical conduction system that we just outlined. So the first step I do is I evaluate this P wave. And so my P wave, if it's coming from my sinus node, will have a certain type of morphology. And so if I look at it on this diagram, I'll come over here to a bigger coronal diagram. My sinus node, which is up here, is located high in the right atrium. And so it sends off a signal into the atria, and we get a wave of depolarization throughout the atria. And that wave of depolarization, because the SA node is high up in the right-hand corner of my atria, it must go down and it must go towards the left. It must go down and it must go towards the left because it's the only way it can go. And so I want to look at the leads that would explain to me that this atrial depolarization wave, because we know that this is creating a P wave, is going down to the left. And so I like to look at lead 1 because lead 1 is perfectly oriented to the left. And so any signal that is traveling leftward will have an upright P wave, right? If it's atrial depolarization, we'll have an upright P wave in lead 1. Similarly, I also like lead AVF down here because it's oriented perfectly north-south And so because it's perfectly up and down, any signal that is traveling negatively or downward, any signal that is traveling downward towards AVF, if it's atrial, will have an upright P wave. And so if I have P waves that are upright in lead 1 and are upright in AVF, that tells me that those P waves are coming from somewhere that are high in the right atria. And when you put all of that together with what we had discussed earlier, with the regularity of the rhythm, the rate, then you can say that that is a sinus P wave. So that is how I say that we have a sinus P wave, is if it is upright, if my P wave is upright in lead 1 in AVF, especially in the setting of all of the criteria that we said before. Now, something else that is interesting about our sinus P wave is you'll notice in V1, if I go to V1, you'll notice that we have a biphasic P wave. And what I mean by that is if you look really closely, it goes a little bit up and then a little bit down, right? A little bit up, a little bit down in V1. Let's talk a little bit about that. Why would you see that in V1? Well, this is very interesting. So V1, remember, is part of our precordial leads that are on the transverse axis. So if I zoom in on my transverse axis here, you'll notice that my chest wall, this is the left side of my chest wall, this is the right side. I'm taking a slice transverse through their body, right? So you have posteriorly the vertebral body and anteriorly the sternum. And so V1 is placed on the right sternal border. And so imagine for atrial depolarization, here's my SA node. My SA node is going to fire off. And because it's sitting in the right atrium, the first part of atrial activation is actually going to be this way, right, as it's activating the right atria. And notice that that signal is going towards V1. So my first part of atrial activation in V1 will be represented by a positive wave. And then what happens is we've actually got this really neat bundle, this little bundle that connects the right and left atria. I'm going to draw it as like a little tube. And that's called Bachmann's bundle. I'm going to spell this wrong. Bachmann's bundle. And Bachmann's bundle is what allows for signal to traverse the right atria to the left atria. And it enters the left atria, and look at the direction that the left atria will then depolarize just a hair after the right. It's going to depolarize kind of towards the lateral side. And so that's away. That is away from V1. And so the second half of atrial depolarization in V1 will be represented by this negative deflection. And so those are actually kind of representing the biphasic pattern of atrial depolarization. And so in V1, you will often see a biphasic P wave. So these are all characteristics of my sinus P wave, right? And so if we look at this ECG, if you look at lead 1, you see we've got a P wave that's just upright, right? You can see it's just a little upright there in lead 1. You can see it even just right there. It's a little bit upright in V1. And if you look down here in AVF, you can see we've got this nice upright P wave. Remember, P waves are sharp. So some people can get them confused with T waves, right? This is a T wave. It's nice and kind of smooth, but my P waves are sharp. So we've got an upright P wave in leads 1 in AVF, which tells me that that is going down and to the left, which is what we expect for our SA node. And then we have what we would understand as a biphasic P wave in V1, and that represents, remember, the first part represents the right atria depolarizing just a hair before the left atria depolarizes. That's just pretty neat, right? And so that can help you understand if one of those waves looks bigger than the other, well, maybe you now understand what they represent. And so now that our atria has depolarized, what is the next part of our electrical activity that we said we were going to be able to measure? Well, the next thing is that our AV node is going to capture that signal. And we said the AV node is represented on the EKG by the PR interval. That's the time it takes from the start of the atrial depolarization until the start of ventricular depolarization, which is how long the AV node's holding onto that signal. And so I like to find a lead, really anywhere that's got nice and sharp P waves and QRSs. And so maybe I'll pick this beat right here to measure my PR interval. And my PR interval is measured by the start of the P wave to the start of the QRS. And so my PR interval needs to be between 120 and 200 milliseconds to be normal. And so that's 3 to 5 little boxes, or 3 to 5 millimeters, right? Each box is a millimeter. And so here we see that that is 4 millimeters, which, if you do the math, is 160 milliseconds, which is normal. And then what you need to do is you need to make sure that this is just only, we're only looking at one beat by looking at that PR interval. So you also need to scan through and make sure that every PR interval remains the same. You also need to scan through and make sure that every P wave conducts to a QRS. Because the AV node, if it doesn't work, then you'll have a P wave without a QRS. Right? So you need to make sure every P has a QRS that is coupled with it. You need to make sure that the interval is the same, because the AV node should be behaving in the same fashion every single time. So that's why in my general approach, I have my next step as measuring my PR interval. What I'm really doing is I'm thinking, what is the AV node doing? So in a normal sinus rhythm with normal function, we would have a PR interval in between 120 and 200 milliseconds, which is 3 to 5 little boxes. So then I know when the AV node is done with its signal, it's going to pass that signal down through to the ventricles, and it's going to generate a QRS complex. And so let's talk about what that QRS complex should look like, and we'll come back to these drawings. So our QRS complex is going to begin when the AV node starts sending signal down the His-Purkinje system. And so our QRS complex is essentially, one thing we know is that if it's narrow, it's because it's taking these rapid conducting fibers, right? Our bundle of His conducting to our right bundle branch, our left bundle branch. And so that should create a narrow QRS. It should create a QRS that's less than 120 milliseconds. We'll look at that on the ECG in a little bit. Also notice that the QRS is going to originate from somewhere here in the AV node, and depolarization should be going in the direction to the apex of the heart. So the wave of depolarization that generates a QRS is going to generally be headed in this direction. Also, just like the SA node, it should be going down and to the left. So what should I see? I should see a QRS that is upright in lead 1. So my QRS should be upright in lead 1, meaning more positive than negative. And it should be upright in AVF, more positive and negative, because it should be headed downward and to the left. If I said right earlier, I don't know if I did say to the right, but I meant to say down to the left. So it's going down and to the left. So we have upright QRSs. We're still going to have some negative forces, right? We might still have some little itty-bitty Q waves, itty-bitty S waves, but we have more positive than negative in our QRS complex, right? And so that's what we're going to see, is a QRS that is upright in these leads, telling us that it's going down to the left. And so if we look here at this ECG, we can see that we've got QRS complexes in lead 1 that are more positive than negative, right? More positive than it is negative. And in lead AVF, you see the same thing. Much more positive than it is negative. And so, because of that, we can say that our vector of depolarization of the ventricles is down and to the left, just like we drew out here. Now, there's something interesting about the order of depolarization of the ventricles that I think is going to really be helpful to understand how the QRS is going to be shaped in the precordial leads, right? So our transverse leads, precordial leads, are V1 through V6. And let's talk about what our sinus rhythm should look like in these leads. So we have the SA node conducting down into the atria, and then our AV node picks that signal up. And the AV node, which is sitting here, passes the signal down to the bundle of His and down the right and left bundle branches. Well, if you look really closely, our left bundle gives off these little fibers to the septum. And so the first part of ventricular activation is actually via these septal fibers. And so the first part of the ventricle to depolarize is the septum from the left ventricle. And we know the left ventricle sits here on the left side of the septum. And so we will get a wave of depolarization just like this across our interventricular septum. And look how small these septal, the size of the septum is compared to the rest of the ventricle. So this is only going to generate a small little wave of depolarization. But notice that that wave of depolarization is headed towards V1 and towards V2. And so our QRS complex here will begin with a little R wave, right? These will begin with a little R wave. And these are called our septal R waves. These are the septal R waves. And so our septal R waves are the first things that we will see in these complexes. Similarly, that wave of septal depolarization is going away from leads like V5 and V6. And so over here you might see little negative deflections, and these could be your septal Q waves. So we'll get little negative deflections in the lateral leads. You can see that on our limb leads as well, where we have depolarization across the septum. And so you might actually see small Q waves or small S waves, or excuse me, small Q waves or small R waves, depending on what direction you're looking at. But we best see them here in the precordium. So we have our small septal R waves in V1 and V2, and maybe some small septal Q waves in V5 and V6. But then, after the septum depolarizes, that wave of depolarization finishes going through our left and right bundle branches, and then we get a nice big wave of depolarization through the ventricular system. And that wave of depolarization is going to be headed generally in this direction, right? It's going to favor the left ventricle over the right ventricle because the left ventricle is greater in size than the right ventricle. It's thicker. Why is it thicker? Because it's got to pump blood to the rest of the body. So it's got to generate a lot more force, so it's a lot stronger. So our wave of depolarization after the septum is headed generally in that direction. And that direction is away from V1. And so V1, you might see deep negative forces that represent that. In V2, you also will see some deep negative forces. But as we start moving through V3 to V4 to V5 to V6, we're going to become more and more oriented with this wave of ventricular depolarization. And so that positive R wave will continue to grow and grow and grow. And so V3, you might have something that's kind of half and half. And then V4, you might have more positive than negative. V5, you will have much more positive than negative. And V5, you will also have, V5 and V6, you will have more positive. So this is called our R wave progression, where our R wave grows as it moves from V1 to V6 as we become more and more oriented with the wave of depolarization. And so that is why we see in our precordium, when I look at my QRS, you'll notice that I've got, first, we mentioned that we will have a septal R wave in V1 and V2. And if you look closely, you can see in that QRS we've got a septal R wave. In V2, we've got our septal R wave. And we have those deep negative forces that represent depolarization away through the rest of the ventricle as it's heading towards more of the left ventricle. And then we see that those R waves are growing the more we get closer to the lateral aspect, and then they become more dominant in V4. And so our R wave should transition, we should have transition to a dominant R wave, where the R wave becomes larger than the S wave. R wave becomes larger than the S wave in either V3 or V4, and that's normal R wave transition. That's representing our progression of that R wave. And so those are all the features of a regularly conducting QRS complex ventricular depolarization in a normal sinus rhythm, where we have a narrow QRS, where if I measure this QRS, right, my QRS is less than 120 milliseconds, or 3 millimeters, right, less than 3 millimeters or 3 small boxes. Our QRS should be upright in lead 1, and it should be upright in AVF, telling us it's going down and to the left, which we know is the direction that we should be depolarizing. And then we have positive forces that are small in V1 and V2, representing a little bit of that septum, and they should grow and grow and grow as we go towards the lateral leads. And so now that the ventricles have depolarized, the last thing we need to do to finish out everything is we need to repolarize those ventricles. And that's our T wave. And so our T wave is usually this nice, smooth wave that occurs after our QRS complex. And our T waves, as you notice, should be in the same direction as our QRS. So if we have a predominantly positive QRS, right, so look at this is a positive QRS, we should have a positive T wave. And why does that happen? Well, I like to use this diagram right here to better understand how this happens. So this is an axial cut of the myocardium. And so here we have our left ventricle, here we have our right ventricle. Here's the left, right, anterior, posterior. And really what I want you to understand from this diagram is the left ventricle, this is the endocardium right here, the endocardium, and right here is the epicardium, right, so more superficial. So this is superficial. And the endocardium is deep. And here, we've got our fascicles. Our fascicles, right? And these fascicles are essentially branches from our bundle branches. Here's one from the right ventricle that carry all of that conduction through the ventricles, right? And so those are what are activating the ventricles. And so as you can imagine, if we're activating the ventricles deep in the endocardium, then depolarization occurs from endocardium to epicardium, right? From deep to superficial as that wave spreads throughout. So that's the direction of depolarization. And remember, depolarization occurs if we draw, like you say, our wave of depolarization, like the membrane potentials, right? Depolarization is this upstroke of membrane potential, right? This is membrane potential. So depolarization is when things inside the cell become more positive. And so this wave of depolarization occurs in this direction. This will make sense in a second. And interestingly enough, the more you get closer to the epicardium, the faster the cells will repolarize. And remember, repolarization is this part. This is the repolarization part, where we're becoming more and more negative again, right? We're getting more and more negative. And repolarization occurs in this direction the cells on the epicardium will repolarize first, and it will spread in the opposite direction as depolarization. And so because of that, we've got it, repolarization is spreading in the opposite direction, and it is generating opposite charge. And so the wave that is produced, which is our T wave, is in the same direction as our QRS, because it is essentially like a double negative. It's double opposite, right? It's heading in the opposite direction physically, and it is generating the opposite level of charge. So that means that the QRS and the T wave should be in the same direction generally. And so if we look, we see that that seems to be the case, right? Anytime you see an upright QRS, you see upright T waves generally. So that's why we say T wave inversions, or when the T wave is inverted compared to the QRS. The only time you can really see differences is maybe here in V1 and V2. They're just oriented in such a bizarre way that oftentimes you'll see like this is a nice gentle but positive T wave, so that's okay. But notice that our T waves are generally occurring in the same direction as our QRS complexes. And so the last interval that we measure is the QT interval. The QT interval is how long it takes for those ventricles to repolarize. And the QT interval is measured from the beginning of the QRS complex to the end of the T wave. And interestingly enough, the QT interval it changes depending on the rate. So the faster you go, the shorter the QT is. So these cells actually respond to differences in rate. And so the QT interval by itself, when you measure it, is not going to be helpful unless you correlate that to the rate of the rhythm that you're measuring. And so our our corrected QT, or the QTC, is the QT interval divided by the square root of the R to R interval in seconds. So what does that mean? So if the R to R interval in seconds gets larger, so if this gets larger, that means that the amount of time between each R is longer, which means that it's a slower rate. So the slower rates are adjusted by increasing the size of our denominator, which actually decreases our correction, right? We correct it by decreasing it a little bit. Because when we measure the QT intervals in our slower rhythms, we're going to have an artificially prolonged number, all right? Because we said that it's rate dependent. And it's the exact same thing the opposite way. The R to R interval in seconds will decrease when we have a faster rate. So when we measure the R to R in a faster rate, we will essentially be able to correct the QT interval by this number is going to go down, and we'll correct it by increasing that correction factor, so that we can understand essentially all we're getting at is, does the QT interval correlate with the rate? So we adjust it for the rate to make sure that for what the rate is, that's an appropriate QT interval. And so the last thing I do when I look at a normal sinus rhythm is I look for pathological Q waves and ST and T wave changes. Pathological Q waves are when the first part of the QRS is a deep Q wave. Remember, the Q waves are the first negative deflection. This is not a good example of a pathological Q wave. That's a normal Q wave, right? A pathological Q wave tells us that we are not able to conduct tissue in that direction because of a prior myocardial infarction. And so in a normal sinus rhythm, we shouldn't have any pathological Q waves. ST and T wave changes. What does that mean? That means ST segment elevation, ST segment depression. We measure our ST segments by taking a look, one, at the baseline. This is our baseline. And our ST segment is this portion from the J point. So our ST segment should be at baseline with essentially the same isoelectric point from after the T wave to the P. So it's kind of like my TP, and this is my ST, right? And so ST segment changes essentially are telling me that there are repolarization abnormalities that are associated with ischemia. And so we should see a baseline throughout all the leads of a flat, flat. And you want to use the leads anatomically. So you look at anatomical regions, for example, leads 2, leads 3, leads AVF, as you can look here, 2, 3, and AVF are capturing majority of signals that are heading downwards. So these are our inferior leads. So leads 2, 3, and AVF are inferior leads. We've got leads 1 and leads AVL, which if you look are AVL and lead 1. These are lateral facing leads. We also have in the transverse precordium V5 and V6 that are also capturing lateral forces. So the lateral leads are leads 1, AVL, AVL, V5, and V6. These are the lateral leads. Remember we said that V1 and V2 capture septal forces, and because of that we designate leads V1 and V2 as septal leads. And then last but not least, V3 and V4 are capturing the majority of that anterior portion of the ventricles. And so V3 and V4, we would call them the anterior leads. And so I'll come back here. The last kind of anatomical region, V3, V4, are the anterior leads. So when you're looking for ST and T wave changes and pathological Q waves, which are our ischemic changes, ischemia should be occurring in some anatomical region of the heart. So that's why you get those changes. And so that's how I approach and understand the findings of normal sinus rhythm, right? I look at the forest and I look for, is my QRS narrow? Is it regular? What is the rate? If the rate is between 60 to 100 beats per minute, then I think that that is something that the sinus node is typically capable of. I then look at what the atria is doing, and I look at my P waves. I see my P waves are upright in lead 1, and they're upright in AVF, and it tells me that they're going down to the left, which is what I think they should. I measure my PR interval because that represents the AV node as it's capturing the signal from that P wave. And I look and see my PR interval should be in between 120 and 200 milliseconds, and it should stay the same the whole time. And every P should conduct to a QRS. It tells me that the AV node works every single time. I then look at the morphology of the QRS itself. Is it narrow? Is it wide? Is my QRS upright in lead 1 and upright in AVF? If so, that tells me that it's probably going down and to the left, which is the way I think it should. I look for good septal R waves here in V1 and V2, and then I look for R wave progression to get larger and larger as I move through the precordium, V3, V4, V5, V6. I measure my QT interval. And an eyeball test that you see that I'll tend to use a lot is I actually look in between two R to R intervals, and I measure the midway point, and that T wave should terminate by the midway point. I look for any T wave abnormalities. The T wave should always be in the same direction of my QRS. I then look for pathological Q waves that tell me that signal is unable to be conducted to a certain region of the heart. And I look for ST elevation or depression that tells me if there are ischemic changes. And I utilize my understanding of cardiac anatomy in all of these anatomical distributions: inferior, lateral, septal, and anterior. And then when I'm done, I put it all together, and here you have a great example of a sinus rhythm. So I hope this helps you kind of understand the physiology of cardiac conduction, apply it to a normal sinus rhythm, and then from there you can see and understand when these things change, and you can understand at which part, anatomical region of the heart, the SA node, the atrial depolarization, the AV node, the ventricular depolarization and repolarization, at which part of this conduction pathway are we faulting, is wrong, where is the lesion, and then you can determine where to go from there. So if you have any questions or comments, please post them and we can chat and debate about them. Please think about subscribing to the channel if you like these videos. Like this video to help support our channel. And yeah, I will see you in another video. Have a great day.